Okay, talking about labor pathology, let's begin with the pathogenesis. The process of labor means when the fetus goes through the birth canal and several changes are going to be done that has to do with the myometrium, the decidia, and the cervix. We're going to be seeing very painful uterine contractions and also dilation and advancement of the cervical. There are three mechanical variables, which are power, passenger, and passage, that are important to take into account in the first, second, and third stage of labor. First stage of labor begins with the onset of regular uterine contractions, and it ends with the full dilation of the cervix. During the first stage of labor, we can differentiate two phases, the latent and the active one. The first one is when the contraction starts and it's very slow, and the active phase is also following the latent phase, but it's more rapidly in changes over the cervix. So the first stage of labor, we are going to have different etiologies or causes that have to do with the power, which is the inadequate number of contractions per minute, or those that have to do with the passenger with abnormal presentation, like for example, breech, phrase, and bro. So an abnormal presentation, as the word says, it's what it is the baby presenting. Or an abnormal position with is the relation between the occipital bone of the baby with respect of the pelvic. Abnormal position can be occipital posterior or occipital transverse. By the way, in between parentheses, the normal position is going to be occipitus anterior. So also we can have fetal intolerance to labor, multiple fetals, and also related to the pelvis, the cephalopelvic disproportion, which means that the head does not fit through the maternal pelvis. So when we have an inadequate contraction, less than 200 units of Montevideo, as you know, the head of the baby is the one that's going to be the stimulus to have advancement and dilation of the cervix. We're not going to continue, and we can have a protracted first stage of labor. When we have problems with the passenger, for example, we can have cephalic presentations, normal ones presenting the vertex, or abnormal ones indicated here in B, C, and D as military, bro, and face presentation. Those are our mal presentations or abnormal presentations. And also a breech presentation that can be a complete breech presentation, a single foot in letter C, double footling in letter D, and complete presentation, in letter B, and frank breech presentation in letter A. So we have a protected phase in the first stage of labor. That protected phase can be divided in latent before 6 centimeters of dilation or active after 6 centimeters of dilation. The active phase arrest or protected active phase is only reserved for after 6 centimeters of dilation, when we have also ruptures of the membranes and we fail to progress in the labor at least 4 hours after inadequate contractions, or at least 6 hours after an IV infusion of oxytocin. Abnormalities of the first stage of labor. We need to relate this to if the patient is primiparous or nulliparous or multiparous. So in protected latent phase, when the primiparous have more than 20 hours in total, or multiparous have more than 14 hours in total. If we're talking about an active, protected active phase, the cervix has to be dilated more, equal or more than 6 centimeter, and we're not seeing a dilation more than less than 1 centimeter over 2 hours. That's going to be a protected active phase. And in the case of active phase arrest after 6 centimeters, remember, we are not going to be seeing cervical changes for more than 4 hours despite of the contractions, or we're not going to be seeing cervical changes after 6 or equal to 6 hours regardless of the adequacy of the contractions. The second stage begins when the cervix reaches the full dilation and ends with the delivery of the fetus. The second stage of labor, we're going to summarize this as in the table with an epidural for primiparous up to 3 hours, for multiparous with epidural anesthetic for up to 2 hours, and without epidural only 2 hours for primiparous, and without epidural up to 1 hour for multiparous. Those are the normal numbers. So when we have an arrested stage, we're going to be seeing that the cervix is going to be dilated in 6 centimeter with membrane ruptures, but we're going to be seeing 4 or more hours even though we have adequate contractions, or 6 or more hours independently of the amount of if the contractions are inadequate, and not seeing cervical changes for 6 or more hours during the second stage. So second stage arrested, it has to do 4 or more hours with adequate contractions, or 6 or more hours of inadequate contractions and no cervical changes. So when we have a second stage of labor, we are not seeing a descendant of the presentation for more than 2 hours, and we need to proceed to do a cesarean section. The most important abnormality of the second stage is going to be the shoulder dystocia. So fetal head deliveries can be delivered when the presentation is the head, but shoulder will remain lodged under the pubic bone, and this is an obstetric emergency. And this is a picture when we have a shoulder malpresentation. The third stage of labor is when the placenta usually separates within 30 minutes. There's going to be another panopto, including some of the etiology of the third stage of labor and complications. When we have a placenta separation in the third state of labor, that's what usually should occur. The placenta separates within the 5 minutes of delivery of the infant, in 50% of the cases, and some of them they keep 90% of them, they stay up to 15 minutes. So we should not attempt to do a separation of the placenta because we can cause harm. The placenta should separate spontaneously, and it should then can be removed gently by traction of the umbilical cord. So before placenta separation is occurred, we can do a steady traction of the cord combined with the upward pressure of the lower uterine segment, that is called the Brandt-Andrews maneuver, to ensure that the placenta can be removed as soon as separation occurs, and provides after we have the placenta in our hands, we should inspect that the placenta is completely, that nothing is missing and all the membranes are out. So abnormalities of the third stage has to do with the separation of the placenta, and sometimes the placenta gets trapped because we have rapid contractions of the lower uterine segment, or because we attempt to pull and did harm pulling the umbilical cord.